Hello everyone. My name's Carl Arnold and I work for Leeds City Council, and I'm here to talk about reducing inappropriate referrals at the front door of adult social care services. And one of the first things I'll do before I move on is inappropriate referrals. I mean, when BITS came in, what we meant by inappropriate referrals is the kind of things where it maybe wasn't appropriate for assessment, but we've sent through to a social work team, and the social work team has a look at it and then signposted it away to a third sector organisation. So that's the sort of thing we're talking about when we talk about inappropriate referrals. If there are referrals onwards, I don't think any referrals inappropriate. The world has changed. There's less about eligibility and less about assessment, and I'm going to talk about that a little bit as we move on. But for this, what we're talking about is them ones that get sent through and then they're signposted away when they get with social work team. I guess we want to sort of decrease the need for a customer or a patient to tell the story twice. And I guess a little bit about me. I've been in Leeds City Council 5 years, in social work 5 years. I've worked on this front door project. I've worked on a project to bring all the health and social work teams together. I've worked on a project to roll out what we call an integrated care record, so we can all see what's happening in mental health and GP world and hospitals and things like that, and a little bit around the hospitals and the delayed transfers of care. This one here is about the front door, and it's about changing that conversation. Before I was working in social work, I was in public health, so a little bit of a background of that sort of health and social work world as well. But I mean, for this, I think rather than talk about inappropriate referrals, I think it's more about changing the conversation at the front door. And we got this behavioural insights team. I might straighten a bit. Is everyone okay if I use an acronym bit now and again? But yeah, we got the behavioural insights team. We got a grant for them to come and have a look at our front door services. And predominantly to just look at that first conversation and just have a think about, actually, some of them referrals that we send through, could we have actually dealt with them a little bit better first time round? And again, just talking about the decreasing the need for a person to tell the story twice and get the same thing at the end of it. We do have a customer access team in social work services, so we don't have an in-house contact centre as such that comes under adult social care. It comes under the corporate contact centre, and we buy full-time equivalents off them and they answer our calls. So we're talking about an environment where someone might be taking different calls on top of our calls, and the problems that brings. Time mostly, you're not just constantly asking them to do social work stuff. They've got other things that they've got to worry about, and you're wanting them to do your bit of the world, and you've got to compete with all the other bits of the world that they do. I mean, for the purpose of this presentation, I'm going to give you a quick overview of Leeds and the sort of, I guess, the environment that Behavioural Insights team were walking into. And then I'm going to give you a quick overview of what the Behavioural Insights team did and some of their results. I've got a few questions for you, and a little bit at the end where you may be sort of a bit of more of a two-way thing. And then I want to sort of talk about what we've done after they left and the things that we've changed and what we've put in place. Man, when I did it at home, it just went straight to the next one. It sort of just... a little bit about Leeds. You see what I'm doing here? I put like that bit thing on every slide. I thought that was quite good. I'm here all day. But yeah, a little bit about Leeds. This represents strength-based social work. I am a little bit worried about his back in that picture. His form's not that great, but yeah, this represents strength-based social work, and buzzword really. It's been people are talking about it a lot. Not just us. It's not just Leeds. But yeah, new leadership came in, and it was all about strength-based social work, less about that assessment and eligibility. So we were sort of basing everything on, are they eligible for services? And now we're sort of saying we'll have a conversation, and we might have a number of conversations based on what's strong rather than what's wrong. And at the end of it, they might go with third sector organisation anyway. But we'll have them conversations and we'll sort of do it in a strength-based way. Moving away from that assessment and eligibility, you're not eligible, so I'll signpost you. We might sort of work with people a bit more, have a number more conversations, and then then we might signpost people. So it has changed, and this was purely about assessment and eligibility, and what we're sending through, that was getting signposted. So the world is changing. And one of the other things is, like I've hinted at, we've got 13 co-located teams. So if you're a nurse, you work in the same team as the social worker for that area. If you're a therapist, you work in the same team as that social worker. And if you're a physio, so it's based on exactly the same GP practices. So if I'm a nurse and I've gone out to see someone and I'm worried about someone, and it goes over to social work, I will be working with a social worker in that team on that case. It didn't used to be like that. The social work team might have been covering maybe an area, and the nurses might have been covering a smaller bit. So it works a lot better. We've got one hospital social work service that does all the discharges. That's a new thing. On site, trying to speed up that between referral and assessment on the wards. And we've got new leadership that's come in and sort of said, don't break the law, don't break the budget, but go and try and make some changes. So it's a really good environment to work in. That, I can't stress enough strong leadership and sort of getting you spurs to go out and try something fantastic. I've put a bonfire on here to talk about the bonfire of bureaucracy. And a couple of things we have changed, and sort of some of them which actually changed while the behavioural insights team were in with us, is that we used to have an initial contact assessment that was 5 to 6 pages long, and that's what the customer service officers out the front door used to read through. Some of them loved it because they were very structured and liked to go through questions. Some of them thought it was just repeating itself all the time and they'd rather have a conversation. We had a 28-page assessment document for social workers, and the big changes are we haven't got that 5-page document at the front, and that 28-page document is now a 2-page conversation record. So we've almost threw a load of paperwork onto that bonfire of bureaucracy and started again. People are happy about that, staff are happy about that. Another thing we've done is our support budget guide, we're trialling it. It's based more about the domains in the Care Act. It used to be based around hours and money, and now it's based on like a sliding scale in domains of the Care Act, and that's currently getting trialled. Again, it's a lot smaller, it's a lot easier to use, it frees up a lot of time. So that's the sort of environment that we're working in. And another thing around the bonfire bureaucracy, we've got something called Leeds Care Record. Has anyone heard of anything about Leeds Care Record in the past? Or anyone stood up? I know it's been talked about quite a lot, but we've got a shared care record that pulls in all the information from our hospitals, from our GPs, from our community health staff, from our social work system, and from our, what's the other one I'm missing? The mental health system. Yeah, so we've got everything comes into one system and we can look at it. So I'll give you a quick example. If I'm a nurse and I get called out on a rapid response, someone needs a response within 4 hours, I can look on a system and see straight away what happened at the doctor's yesterday, and I can see that that person's got a social worker and what the social worker's name is, and I can see that that person's got a package of home care and that it comes in 4 times a day and it's delivered by this organisation. Really sort of changes a nurse's view of what she might do when she gets in that situation. If she knows someone's going to come and see her in an hour, or they might want to talk to the active social worker. That didn't exist when I first started. We used to phone round and often go on and do 2 or 3 visits, different staff. So fantastic, inventive. I can't sing his praises highly enough. And one of the things I've done is I've worked with the Leeds Care Record team to almost design a version for the front door. So they don't see the GP stuff, but they do see that there's a social worker, they do see that there's a mental health worker, they do see what ward the person might be on. So it really gives the customer service officer a lot more information when they're dealing with the customer. So that's just we've got strategies. We've got to feed into these strategies. What I like is the best care in the right place at the right time. I think everything we do, if we get it right at the front door, feeds into getting the best care in the right place at the right time. I've got a really good example of someone phoned up and very distressed state. Definitely a state that would have turned into a safeguarding referral. Definitely a state that maybe would have prompted the CSO to inform the police. And before the CSO, Customer Service Officer, sorry about the acronyms, I slip into them from time to time. The Customer Service Officer checked Leeds Care record and can see that they had an active worker from the Mental Health Trust. So while the person was on the line, we talked about, have you got any more support? Oh, I can see that. Would you like me to contact them? And they start a three-way conversation to contact the person who knows them best, a little bit of a handover, and then some feedback from the Mental Health Trust to say that's fine, it's something that happens. I guess the other option used to be potentially contacting the police and things and getting telephone calls from people who you don't know. And I think it's a real example of sort of looking after the customer. And strategy-wise, we're promoting a stronger focus on prevention, we're promoting self-care, and we're maximising the benefits of technology as we're doing it. So, I mean, I'm not a big strategy person. I think just look after the customer, and the strategy sort of looks after itself. And across Leeds, we've got a model about better conversations. I'm not going to say much about, I would say the one for us is focus on what's strong rather than what's wrong. And I think I'm going to talk about the bit intervention next. And there's a real focus on what's strong rather than what's wrong with some of the recommendations they've done for our conversation. So a little bit about BIT. Well, the goal of the project was to increase signposting at the front door, decrease the amount of signposting in social work teams, but also embed that strength-based conversation that we're looking for and do away with that 5 to 6 page assessment document that we were using. I mean, the second bit was the analysis. I can't speak highly enough about the analysis. They went through everything, call data, data from our social work system, every single referral that a customer service officer had made over a 13-week period, and then they came back in and done it again, and they looked at every single call that the customer service officer had made. We transcribed a load of calls, pseudonymised them and tried to transcribe them, and they looked for themes of what we weren't doing. I can't speak highly enough of the initial analysis. And what they come back with is some sort of evidence-based solutions of how we might trial something. And the trial itself was, I'll read it out, a step wedge cluster randomised controlled trial. What that means is they got 2 people in a room at a time, they trained them, they went away and done something different, and then next week they had another 2 people. And they just, week to week, they monitored the changes to see if anything was different. Were they acting different? Were they sending referrals in a different way? Had anything changed? And this went on for around, I think it was about 12 weeks or so. And then they did us a final report to tell us some of the outcomes. Now, it sort of highlights the good analysis. Before we started, there was what we call inappropriate referrals. They had a look at our data from 12 months ago, and around 10% of all calls turned into what we would class as an inappropriate referral for the sake of this trial. Now, when they carried out the trial, it dropped to 7.6%. And they indicated that BIT's intervention had nothing to do with it. They said it had dropped naturally. We'd actually done something better we'd improved in the last 12 months. From what things I've told you about Leeds, can you have any thoughts on why the amount of inappropriate referrals that actually arrive at the contact centre dropped in 12 months?
I don't know, have you done a really great job of communicating your what's strong, not what's wrong message across areas of the work?
Yeah, I think there's a number of things. And one of the main ones is about them integrated teams and the sharing the integrated systems and stuff. We're actually getting less inappropriate referrals from other professionals. And I think that was the big change. There's less of them coming through the contact centre. So, and I guess that's down to, if I'm a nurse now, I work in the same team as a social worker. Whereas maybe in the past they didn't see each other unless they maybe had to go to a meeting together. So maybe there's more of them conversations happening in a team, and there's less getting escalated through a contact centre to go to a social work team to then be closed down. So I do think there's something in there, and it doesn't account for all of that, but we have had a real drop in our figures of the amount of professionals that are coming through the contact centre and turning into an inappropriate referral. It's a real positive to start with, and why that indicates that the bit analysis was good is, I'm guessing if it was a bit shoddy, they could have claimed that for themselves. They could have said, we done our intervention, and there was a drop, job done. They didn't. They said it definitely wasn't to do with our intervention. It's something that has happened naturally, and I thought that was great.
Why did you choose to do that at the same time?
What's that?
Because you could have rolled out your new systems that gave people access to these integrated bits of information, and then tested calls to see how that was working before you then tried the training thing to see if that added something extra on top.
BITS was a piece of research, what we wanted to maybe act upon, maybe not, depending on how it turned out. So we brought them in to just do that research. It wasn't 100% whatever they recommend we're going to go with. Do the research, do a report for us. If we like it, we're going to maybe implement this. And again, it's a huge city. Leeds Care Record, it's massive. It's everyone's involved in that. There was no way. The integrated teams was the push towards integration years before. So these are all things that have been put in place years ago and are gradually just dripping through into the system. And even now, there's probably people who are not maybe making the most of technology, even though they've got it at their fingertips. But yeah, it's something that's been put in place over the last few years and is sort of dripping through. And maybe we're just starting to actually see it there. So what BIT recommended was we try what they called the OAT process. And now you've got it in front here. We've slightly adapted this. It was worded slightly different, but the domains were the same. And it tells us to set out the potential outcomes for the customer. We didn't do it. We went straight into the conversation with the customer, them telling us what was wrong. That was it. We didn't stop and go, at the end of this call, we might. And I was told by BIT that it was a sense of loss. So everyone phones up for a social work referral. And if you give them some advice, they haven't got what they came for. So there's almost a sense of loss. If you send them to a third sector organisation, what does team mornings, they say, I phoned up for a social work referral, I haven't got one. So there's almost a sense of loss. So we never set out them outcomes. So quite simple, we set out 3 outcomes. We might give you some advice. We might send you to another organisation, such as a third sector organisation, or we might create a referral into social work. So it just sort of sets the scene before we start. Really simple, but we didn't do it. The second one we got ask. Outcomes ask. So the second one, you're into your conversation, and it was about them developing some prompts that are going to help us. I mean, we've sort of split them into 2 things. We've started with what's strong, what's your typical day like, and then some prompts to say, do family members help? Have you got any equipment currently? Do you get out to any organisations? Them sort of prompts to sort of really build a picture up about what strengths that person's got. Get them to tell us who's helping, where they're going. And then afterwards, what's changed? So why have you contacted us today? And then you can maybe start to have a conversation to say, well, I can see that someone helps you every morning. I can see that you've got help on an evening. Is it during the day? And you can start maybe, as a customer service officer form, does this person actually need a home care package, or is there something that I know can help them in the local community? We've got things called neighbourhood networks. They'll come and do home visits and things. So really sort of focus them around by doing it in that way to think, I can see that you're okay on a morning, you're okay on an evening, is it just during the day? Them sort of questions. So it sort of gives us that. And the very last one was try. And we introduced try. If we're going to signpost someone, why don't you try that service for 2 weeks and give us a call back? It almost takes away that we're getting rid of you. It's come back to us, tell us what it's like. We have put in very small areas, we've put in ourselves calling them back in 2 weeks to ask them how it went. We'd love to do that with everybody, but it's a lot of customers and we haven't got the staff to do it just yet. But we are trialling it in a couple of areas where we actually call them back. So we say, why don't you try that? And we'll give you a call back. And we're doing that, and we're just sort of measuring how much resource it takes and also what the outcomes are like, how many of them come back to us. So that's really our what's in front of you. It's our conversation note. Outcomes, ask, try. Used to be an 11-page document with lots and lots of questions that kind of repeated. So it's a 5 to 6 page document with lots of questions that repeated themselves. Bits to improve on. These are all the customer service officers that did the trial. What I noticed from this straight away is lots of them are... These points here are the average amount of inappropriate referrals they sent through. These bits here is the sort of interquartile range week to week. So this person here is almost perfect all the time. Roughly about 3% of the work is classed as what we would class it as an inappropriate referral, and they're very rarely stray from that week to week. That's fantastic. If we could learn from that person, get everyone like that, then I'm guessing it'd probably be too perfect. You probably couldn't. But what I thought is about 78% of it is under 10%. So most people are doing better than the average. And what this also told us was we might be focusing on everybody, constant, the same training for everybody, the same memos for everybody. That we need to just focus. This might be learning styles that these people might just need to focus our training a little bit more. So this was really handy to the people who manage the customer service officers. It's anonymised, so they don't know who them customer service officers are, but it gives us an idea how we might measure performance and then maybe tailor our training and sort of bring that down. We've cracked it. But like I say, I think 78% of it is perfect. The actual results themselves by bit. Now, one of the things about us getting a reduction before we started is that based their intervention was looking at that 10%. How much of that 10% can we change? And when they started the trial, it was 7.6%. So immediately they had less to aim at. What we did get is a slight reduction during the trial. Like was said in that hall about one of the other, it wasn't significant enough for us to honestly say it was because of this intervention. But I was quite happy that we had a reduction before we started. And actually they saw a little bit of a reduction as well, and I thought it was something to build on. These are their recommendations. Continue to monitor the impact of the approach. We're doing that, and I'm going to talk a little bit about how we're going to do it. Focus on narrowing the gap on them CSOs during the last graph, and we're doing that. We're looking at how we look at performance and tailor training to be more specific towards people. Focus on self-referrals and referrals by friends or family members. More likely to send it through if it's a friend or a family member. If it's a doctor, maybe you've just got all the right information there. If it's a friend or family member, it might be just a bit more emotive. And a customer service officer might err on the side of caution and send it through. Now, we've got social workers that are up there with the customer service officers. So we're going to put in a plan to focus more on them self-referrals and the referrals by friends and family. So the social worker might maybe offer a bit more support to the customer service officers for them types of referrals. And consider how to make signposting easier. Crack that then, we've cracked everything. We're looking at our signposting tools. We've got a more structured way from the signpost now, but we're also trying to put all our signposting information into one place.
Well, I'm a bit new to this, sorry. So you mean, so the staff have a list of the different options that are available that they can point people towards rather than going through the automatic?
Yeah. It's a big city, so the Mental Health Trust might commission something, and Leeds City Council might commission something, and we'll go through a process the same. We've all got these websites with great information on. How do we get it in one place that's really easy to use?
Is it not just for staff, but for customers as well?
Everybody, yeah. $1 million question, isn't it, for a city the size of Leeds? There's always something commissioned that's got a load of information on, and you think, oof, how could we get it all together? But we're actually looking into it, so it's maybe something that we can share the learning on as we go along that. Yeah, completely, yeah. Well, we've sort of done something locally. We're just like all sharing our information into one place, and it's probably just going to feed into the biggest project of can we now get it on an official website. But they're kind of like all sharing their information now, and so it's kind of there. But there is 3 or 4 different websites that you might look at. I mean, that's probably the thing. So this is what's changed. We've changed the process for the CSOs completely. It says outcomes, ask and try as they move along, and it prompts them to go and have a look at Leeds Care Record as they're moving along. So they start their conversation there, and they go there, and then they might check a system, and then they might go there, and then they might think, I haven't got enough information, and I'm not talking to the service user. Can I give them a call back? That's all new. We didn't used to do that. They used to and the only option was signpost or social work. So there's a few more things for them to think about, and a few more options, stop-off points in the way. And what we've also done is introduce something called talking points. These are like GP appointments, but social workers, and they're in your community venues or GP. They move around the city, and every neighbourhood's got one, and you can book it in. We've got a booking system that we've designed for the customer service officers to book someone in. You can get in within 11 days.
To go to get advice on what's available?
To a social worker. So you might even get like start an assessment then.
So what I don't understand that. What is it?
A talking point.
Yeah.
It's a community venue with a social worker sat there and an appointment system. And instead of them travelling around the city, they might see 4 or 5 people in one day.
Okay.
So it's more some mid-level stuff you might send there. Yeah, but then again, that frees up some of the other stuff as well. If you do need a home assessment, there's less people going for a home assessment. So we can book people in from the customer service office. We've never been able to do that. That's fantastic. That's a real change. It stops people ringing back as well and saying, where's that assessment? Because it's Thursday next week. They've got an appointment. We've sent them a letter out. I think there's one in every neighbourhood now, a talking point, and we maybe build on that, but it's a real change. And another one is we just asked them to log things a little different on CIS, our client information system, our system. We put everything on. We've asked them to log it a little bit different so we can monitor this a little bit better. And I'll give you a quick overview now. So performance-wise, we've looked at like quantity and quality. So we've always been able to do this top one. We've always knew how many phoned up, and we've always knew how many we answered. Signposting, any information and advice or signposting, we now taken the person's details on the social work system, and we're putting a copy of the conversation next to it as what we would call a non-referral contact. Again, for the customer, by the time you see a social worker, they might be able to see the 2 or 3 conversations you've had in the past with a customer service officer, and that and what happened. We didn't used to be able to do that. They used to be logged somewhere, and you could just see how many people had been signposted. So that's a real change. It's a real positive. What we can do now then is see if they come back into service, because it's logged against a person. And we are starting a little bit of this, phoning someone back in 2 weeks to see how did that go. Did you go and see that neighbourhood network? No, I didn't. No, I'm a little bit nervous. Okay, and maybe take a different path with them. So we're actually starting to do that. Failure demands, do you know when people ring up and say, where's that assessment? Where's that grab rail that I ordered last week? It's a failure in the system that creates a demand for customer service officers. So it's not there yet, but we're going to log that in a place so we can measure it, and hopefully it comes down over time. And finally, that last one, measure referrals, and a bit like the behavioural insights team did, measure how many go on to assessment, measure how many go on to receive a package of care, and again, measure how many go to a talking point. This sort of feeds into them John Bolton measures. Do you know, have you seen the John Bolton measures around measuring performance in social work? It's a good read, have a look at it, and it's a real sort of, it's around this sort of thing. How much do we do? How much of it goes to assessment? How much of it goes onto a care package? We're starting to try to change so we can measure things like that. Oh.
Sorry. Yeah. If you've referred someone to, say, a partner organisation who may be able to help them,
yeah.
Obviously they can't access the system to
No.
make a note. So yeah. So I was saying otherwise, thinking otherwise, you'd know someone hadn't followed something up, and then that would give you a greater imperative to contact them and say, why not?
Yeah. The ones we commission, we're thinking, do you know, like we commission some third sector organisations, we're thinking with them it could be part of their performance reporting, to maybe report on some of them outcomes. We couldn't do it with every T group and church group in the city. That's why we're thinking, do we call them back? Do you know, in 2 weeks? It's a huge job because there's 30,000 people signposted in one place. It's probably another team somewhere. But we're starting to do it with just certain areas to have a little look to how much does it take, what does it tell us. I mean, I'd think it was great to get an option from an opinion from a third party bit. I thought it was fantastic. And proper change might be more than a conversation. It might be systems, it might be processes, it might be a whole host of things. I thought the BI intervention was a fantastic starting point to build on, and then build another 5 days training in. That's going to incorporate lots of other things, but I thought it was a fantastic starting point. Keep staff engaged. We updated them all the way. After the BI intervention, we said we're going to be using this. We're going to do some training. It's going to be delivered then, and they felt engaged. We're ready for it. Strong appetite for change from the leaders at the top as well. You know, all the way down, it just went all the way down. Strong appetite for change and good relationships, I found, from the customer access people who were delivering it for us, and social care who wanted the change. Really good relationships. I've just got a question for the room. All I wanted to ask is, what would you like to change, and what barriers do you think you'll encounter when it comes to like the front door?